York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. I would like to call a motion for the adoption of the minutes of the Strategic Planning Committee meeting held on April 12, 2021 and July 12, 2021. I will be calling each one of the members for the vote. Jose?
Yes.
Dr. Allen is representing Dr. Katz. Dr. Allen?
Yes, here.
Thank you. Frida? Frida? I think Frida may be.
Yes. Sorry.
Thank you, Frida. Thank you. Sally? I think the muting is having some problem. Give me the heads up.
All right.
Yes, yes. Thank you, Sally. Next, we will hear from Mr. Ziegler and Dr. Wei as they provide an update on the system dashboard. Please, Eric and Matt.
Good morning. Thanks for having us today. Excited to be with you to go through our strategic dashboard and some system updates. Does this work? Oh, yeah, thank you. So we thought we'd start at the top with a pretty high-level overview. We shared this slide in the Finance Committee as well, but I think to us it captures pretty well where our system is after several years of our updated strategic pyramid and strategic dashboard. A bit of a focus on the financial sustainability pillar here, but it really touches on everything. So I thought it was worth discussing. We've overall achieved $1 billion in recurring revenue generating and expense reducing initiatives. So a substantial step forward in stabilizing our finances and preparing for the future. Of course, the implementation of Epic, I think, has been more successful than really anyone could have hoped, increasing our case mix index by over 30%. And then the true, pleasant surprise and amazing thing to build upon is getting to over 70% MyChart activation, making us a real national leader on that. Metro Plus membership has increased nearly 200,000 since 2015, and 100,000 of that just since January of 2020. And along the same lines of connecting more New Yorkers to coverage and care, NYC Care is fully implemented citywide, and enrollment is creeping up towards 100,000 members. So a fantastic set of high-level results we thought we'd share there. And then, of course, no more important strategic element of health and hospitals performance than our COVID response. Just a few listings here. It could go on for pages and pages, but the sheer response to the surge, the ability to pivot to telehealth, Eric and the team's amazing work helping our workforce and other healers around the city. 4 million tests, including 1.5 million in public schools. The isolation hotel program reaching 90% of positive cases. Amazing vaccination success with over 1 million vaccinations around the city, including Eric's daughters and my daughter on Friday at Harlem. So we're very grateful for that. Just a thrilling thing for health and hospitals and our families.
Great.
So again, another picture just of our budget strategy that we thought we'd take a snapshot of. A few key areas that we launched in 2021 that we tried to continue through and evolve in 2022. Our operating rooms and generating more revenue from some of those key areas in our facilities been very successful, and we're building upon some of that same performance improvement approach with specialty areas in radiology this year. Our focus on value-based payment, the second row there, had some great success in 2021, and we'll be building upon it this year, including with the implementation of the Public Health Corps, which is an exciting part of that work. Revenue cycle and managed care have been major drivers of our financial success for the last 4 years plus, and I think we can build on that success this year, particularly with reducing denials and a few new key contracts with insurers. Our ambulatory care and telehealth, keys to our access to care and care experience strategic goals, With the MyChart growth last year and the launch of many major telehealth initiatives, I think it's really about optimization and further growth this year, so we can have a lot of success there. Always the most important line on any strategy for us really is this one: be great at the basics, right? A number of key examples of that, but last year, post-acute and IT, pharmacy and lab, making some key operational improvements. This year, community care is doing many of the same things, and a lot of continued room for growth and improvement in pharmacy and supply chain. And then, our nurse staffing and physician workforce plans around the system are part of the key to our, sustainable budgeting and operations. So those will be some important things for this year. And then our final line, we always have big and important things working with the state Medicaid program. Our UPL conversion proposal was approved and is being implemented from last year. And then we'll continue to work on some Medicaid redesign team endorsed models like our special populations proposal throughout this year. So a snapshot of our budget strategy and how that all fits together. Of course, we also at the financial level, we track our major external risks. Some of the key federal initiatives like FEMA reimbursement, the DISH delay, and the DISH FMAP situation have been addressed. We continue to work with the state on those Medicaid initiatives that are works in progress. Thankfully, the city and state budgets were not the major risk last year that we feared they would be. So that has been averted, and with our delegation support, significant FEMA reimbursement has come in, which is excellent. The vaccine mandate, again, has been tremendously successful in getting people vaccinated. Our expenses around temporary staff and preparing for that eventuality is something we have to work into the financial plan and continue to play out, because it was a significant investment to be ready for that big day. And now, Deb will go through a quick slide on our other external and regulatory updates.
Thanks, Matt. Hi, everyone. Nice to see you. Top of the news cycle for everyone, as Benny mentioned earlier, is the passage of the infrastructure bill and the ongoing negotiations regarding the social policy package, ideally for the week of November 15th. That's apparently what the deal was. That contains some provisions that are going to be relevant to us, particularly GME slots. The one interesting thing I would say about the more traditional infrastructure package is that it does include support for expanded broadband, which is something that ideally will be helpful for continuing our work and others' work around the country on telehealth. In terms of the regulatory focus, we continue to see the White House focusing largely on COVID-19 response, as you would expect, including the work towards vaccine mandates, and we'll talk about that a little bit down in the state section. A regulatory agenda is starting to evolve. It's a focus that I think we share in terms of our values and our work. There's work on coverage, equity, value-based care. As I said, the regulatory agenda is continuing to evolve, but things that we are seeing thus far are very favorable to the things that we hold dear in the work that we do. On the state level, things continue to evolve and get into place as Governor Hochul and her administration emerge. Commissioner Bassett, many of you will remember from her work as the Commissioner of Health at the City Department of Health and Mental Hygiene. She will be the Commissioner of the State Department of Health, which is, exciting news for us. She trained with us. And again, in terms of our values, we are very, very much aligned. She is meant to start the first week of December. So there will be, I think, some exciting initiatives coming out. Obviously, we are starting the process, the annual process, the state legislature and budget process that will begin in earnest or officially in January. We and others have already begun the work, though. We have started to set up meetings with key committee staff, with key legislative staff to continue to advance our principles and our priorities. And we continue to work with the state on their steps towards a Medicaid waiver. On the city side, and it was an exciting week last week, Election Day, not a ton of surprises. Incoming Mayor-elect Adams is, as expected, won the election, as did most of the citywide races. I think it's going to be, we're I feel like broken record, but in terms of aligned values, that which the incoming mayor has discussed in terms of healthcare, and more importantly, in terms of social determinants of health, I think we are very well aligned with what he and the incoming administration plans to do. On the council side, what was interesting is seeing a little bit of a surge from, there's few Republicans in the council, but they outperformed relative to their small power there. And I think that'll be really interesting as we look towards the speaker's race, which is going to be the next big horse race. And, in terms of the legislative package, how the new council and the new mayor will work together. And we are working through remaining budget issues with OMB and with our colleagues in finance. That is a quick overview.
Thanks, Deb. Any questions on these external issues or our broader financial strategy and status before we dive into the dashboard?
Hi, Matt. This is Michelle. I just out of curiosity, and you may not be able to answer it between you and Deb. Has the mayor-elect verbalized any plans for balancing the budget? I think we have a bit of a deficit.
I think it's going to be an interesting budgeting cycle, both on the state and the federal and the city level, as the influx of federal funds, which was in many ways a one-time, starts to go away. I think the issue is going to be, how do you capitalize on those funds? How do you create security for the kind of programming that we're all interested in?
Deb, focusing still on the mayor, are we working on preparing some kind of briefing document for him?
Yes, ma'am.
Yeah.
Yes, we
particularly, he's very interested in MWBE, which is important. His concerns about diabetes and high blood pressure, and I just would urge that we not make it like, you can have a two-piece document. You have one that's a broader overview and one that has a lot more details. But you can have a broad brush stroke and a briefing document that has supplemental information. I think that would be good.
Thank you. Points well taken.
Can I add to that? I don't know exactly how you would think about engaging the board in that process, but it would be, I think it would be useful to get some input in terms of what kind of information gets presented, how, just in general, not into all the details, but at least at that level. So if you want to think about that, Deb, I would like.
Will do.
Yeah, thanks.
Cool. I appreciate that. Thanks, Jose.
Since we are asking questions from Deb, let me just ask Frida if she has any questions or any comments.
Thank you, Benioski. Deb, shifting to the federal side, what are we hoping to see out of this? I know there wasn't too much on the infrastructure side. You mentioned the broadband.
Yeah, that's right.
Which is interesting. I hadn't thought about that, but on the social side,
Right.
What do you think we're looking for there?
I mean, one of the big things, as I said, is GME slots. That's something that's been an ongoing advocacy priority for us, and frankly, for a lot of hospitals around the country. That's meant to get folded in. There's going to be, ideally, if the format holds, there'll be a number of things shoring up Medicaid, Medicare, public health provisions, I guess you would say, support for that. So I think there's going to be elements of it that, if they are not directly helpful to hospitals, are going to be helpful for the work we do and the patients we serve. There is supposed to be funding, particularly for some home and community-based services, as well as potentially FQHCs. So we'll see how that shakes out and potentially get a piece of that. Yeah, I think, if you think about it in terms of our larger priorities and sort of the larger wraparound of what we do, this could be something that's really important to us.
Thank you.
Sure.
Any other questions for Deb? No? Matt, would like to continue?
Great. Okay. We'll go into our dashboard performance on our key items. Eric, could I turn it over to you for quality and outcomes and care experience?
Sure, thanks, Matt. Great to see everyone. So the two that we have here as positive trends, post-acute care all-cause hospitalization rate dropped from 1.85 days per 1,000 to 1.73. So that's good. But our target is 1.0, so we're still working towards getting it down to that 1.0. Hemoglobin A1C is rebounding nicely from what we suspect was a COVID-related gap in terms of being able to get our diabetics the A1C tests, as well as getting them in for care, no matter how much we try with televisits and welcoming folks back to our in-person clinics. But it is rebounding from 61% to 63.7%. Target has not yet been met, which is 66.6%. Go to the next slide. So on care experience, on our inpatient side, we continue to see the overall rating trending upwards, and we have now beat our target at 66.96%, up from 64.96. The target was 66.3. On the outpatient ambulatory side, recommend provider office, also trending up ever so slightly, and getting so painfully close to our target of 87%. So I guess if we round it to a whole number, it would be 87 there. And then as Matt mentioned, my chart activations, can't believe that last year our goal was 25%, and we've clearly blown that out of the water, and we're at 69%. And we set a very ambitious target of 75% that would put us almost in Kaiser territory for my chart. Matt, I'll turn it back
And
to
then
you. Yeah.
Sure, thanks. And our two most positive trending financial sustainability metrics. One is one of our key IT projects for the year, our enterprise data center migration. The move from the SunGard data center to QTS is ongoing and 100% on target. It will remain there as the work keeps progressing. And then a key one for us, the percentage of uninsured patients who are either enrolled in health insurance coverage or in financial assistance, a pretty meaningful jump from 72% to 81% last quarter. So that's exceeding our target, and a great sign of success that heading towards that goal of every single patient coming into our system, we either help get enrolled in coverage or in NYC Care to make sure that everyone has the most affordable care possible. So those are our some of our positive trending measures. Another key one for us that's trending positive are our access to care measures. So exciting to see this. Our rolling 12-month of unique primary care patients in the system jumped up from 370,000 to 404,000. We'll set a new target here for 2022. But that's a great sign of success to see us moving into a more post-COVID quarter and getting back up above that 400,000 mark. E-consults continue to be one of the key ways that we work to open up specialty access. And over the last quarter, we jumped up from 82,000 to over 100,000 e-consults, which is just tremendous. Again, another target we'll update for next year as we've significantly exceeded that and really working to optimize how all our clinics around the system use it. And then, of course, NYC Care Enrollment, as of the quarter we're measuring here, was just short of our 75,000 target, and I think we'll exceed that in the next quarter that we are measuring. So as we jump ahead to steady trends.
Yeah, with our quality and outcomes, so this is an IT metric, it's integration of our biomedical devices. Targets 100%, we were 80%, and there was an adjustment for the denominator, which you could see in the footnote, projected goal 1,700 by December 2021. And so I think it was a increase in complexity of the devices that we wanted to integrate that is leading to the 80% and not 100%. But we hope to catch up soon.
And then 3 steady trends from our financial sustainability pillar. The first is the ratio of patient care revenue over expenses, still significantly above target at 74%, but did not rise above that. I think a very substantial number, and I think being in the 60s is probably closer to where we'll be as some of our COVID rate enhancements and other revenues return to normal, but stayed steady over the 2 quarters. The percent of Metro Plus's medical spend at health and hospitals has stayed steady and frustratingly below target at 38.6. Very difficult to move that given the sheer scale of the enrollment growth that Metro Plus has seen over the past year, but continues to be a focus of ours in meetings with their team and focus on our panel management at the primary care level and opening up ready means of access for new Metro Plus members. So we will keep working hard on that one. The AR days per month is remaining steady at 60 days. Our target is still lower than that. I think the amount of self-pay balances related to COVID and COVID testing remains a challenge to nudge this down to where it is, but I think our facilities are working hard on it. We track it closely in all of our monthly budget meetings with facilities. So those are our steady trends. We have a few here that are negative trends between the quarters, but remain better than the target. So Eric?
Yeah. So the percent left without being seen, as a reminder, this is the emergency department metric of patients who check in at triage who leave before they've seen the provider. We had the best numbers that we had seen, certainly since I've been here, but I suspect ever, coming out of COVID. And I think that was volume related, as well as some of the patient flow improvements of not having admitted patients boarding in the emergency department that we basically had to do during the COVID surge. And so we still remain below target of 4%, which is very, very good for trauma centers, teaching centers, and public hospitals. So working really hard to keep this under 4%. It's at 3.7 right now. Financial sustainability. Matt, you want to talk about this one? AR days for post-acute.
Sure, it's just our accounts receivable in post-acute. They've done a great job getting it under 55 days. I think a few kind of very long waits on significant payments from health plans can stretch that out. But I think they're very focused on this. It's part of their plan for the year, and hopefully will remain under 55 through the remainder of the year.
And then for our culture of safety metric, total wellness encounters. So a reminder, these are one-on-one debriefs, H3 debriefs, group debriefs, wellness rounds. We had 688 documented for this quarter. It is down from 916, but this was expected, coming out of the COVID surge where the need was much greater. But we hope to reach a steady state above a target of 600 per quarter. For this one, pretty alarming drop from 55.7 to 44.7 for follow-up appointments kept within 30 days after behavioral health discharge. Almost unbelievable. And then when we dug deeper, it is because there was a significant change in how this data is collected. We switched from a internal data repository called PDMS to Epic on this. And so during this quarter, there was a lot of training hiccups and difficulty getting staff to document the follow-up, how Epic is capturing it. And so I would put a big asterisk next to this one until we can get the training back up in our new baseline. But I think for right now, we should leave the target at 66%.
Okay. Some of the new measures we're able to report out on this quarter are in our racial and social equity domain. As I think some of the board members heard in the Equity, Diversity, and Inclusion Committee, making good progress on our chronic disease dashboards and how many of them can report out on race, ethnicity, and language. Our target is to have all of them reporting on that. So far, we have 2 out of the 5 key ones reporting, so that is a good sign of progress. Similarly, the percentage of total procurement spent on MWBE is at 28%, heading up towards our target of 30, which is excellent. And then we continue to work on getting a baseline for the percentage of new physician hires from an underrepresented minority. But if Eric or Yvette or others have anything to add on that one, I think we'll keep reporting on that as we go.
Yeah, that's correct. That's correct. We are currently at 31% minority of physicians, and we will be doing a comparison calendar to calendar year for January. So we're collecting that data, and we're narrowing the gap on any missing data of self-identifying physicians.
And then our final area, Eric, you might want to jump in just on our COVID-19 metrics for Q4 of FY21.
Yeah. So for this one, I think all the numbers are as expected, following sort of the waves that are occurring. So you can see through April 1 through June 31st, we were coming out of wave 2, so less tests than during wave 2, which is the 1,194,000. The total number of positive tests also matched that, right? Wave 2 in New York City, a lot more tests in the first 3 months of the year. Post-acute infection rate much better in Q4, and then vaccine numbers keep marching up. This does not capture our vaccine mandate and other mandates that have occurred since then, so we'll likely see a bump from those. And then the percent occupied beds continue to welcome back our non-COVID volume, which remains fairly steady in Q3 and Q4 there. And very excited that we started vaccinating 5 to 11-year-olds last Thursday. And for next quarter's presentation, we'll add in COVID-19 vaccine for both the 12 to 17 and the 5 to 11 age groups here.
Great. And then this is our glossary of the dashboard, and then just the final slide is our overall picture. On any dashboard like this, I was a mentor once told me, red is your friend, right? You want some red to know where you're targeting and where you want to dive in. So enough red, I guess, on there, enough for me. But we're working hard. We'll have updated targets, as I said, for calendar year 22 at our next meeting. But with that, we'll pause and take questions from the board. Thank you for your time.
Thank you, Matt. I would like to go through the list of each one of the members. Jose?
I don't have any questions. Thanks for the report.
Thank you. Dr. Allen?
No questions, thank you.
Thank you. Frida?
I have a few questions, if that's okay.
That's okay, Frida.
Thank you. So first on just the MyChart activation, which I think is terrific, but I did want to ask the question is, does this include for the testing activations, or have we isolated out? It includes all of them.
It does, yes. The last time I looked at the data, interestingly, which is I was very pleasantly surprised by, the percentage activation, if you just isolate our primary care patients, is actually a little bit higher than the total universe, right? Which was, that was my fear, that this is all just people signing up for testing, but our core patients are not engaged with it. Hasn't been the case the last time I saw that that cut of the data. So we'll keep working on it there. And I think the way we track it most closely this year, something that I've been working with our facilities on is the provider responsiveness, right? How quickly are providers responding to messages within 48 or 72 hours? That's a key measure we want to get up, towards 80, 90% response within 48, 72 hours would be excellent. That's what keeps people engaged, and we'll keep that number high as we keep going.
That's great. So you do have the bifurcated data, because that is really interesting that the primary care is actually higher, because I would have thought that, myself having signed up for the testing, that most people, a lot of that might be coming from the testing activity. But so that's terrific. And on the target, I'm just curious, Eric, you made a comment that you're approaching Kaiser levels. What is Kaiser?
They're in the 80s. That was the last I checked. Is that your understanding as well?
I think it might be higher. Honestly, they're just make it so standard. But yes, they've always been the leader on this. In the 80s or 90s. Right.
But so 75 is a good target for us. It sounds, for 69 right now. And so that's actually most of my other questions are really more about some of the targets. So on the financial sustainability front, for example, I think this is terrific what we're seeing on percent of uninsured patients. We talked about that a lot here before, how important that is, and 81% is just amazing. Do you think that there's something going on that we've learned to do better, or is it just the cyclicality of things? I mean, we're clearly far exceeding our target right now at 76%.
I think, yes, I think Margie and the team work very, very hard on this. The inpatient rates have always been quite high, which is great. I think there was a jump in the ED side of it, which is good to have a workflow there that's a bit more rigorous in just connecting with people. The next big jump, or the thing that I hope keeps us up here and takes us higher, is that outpatient side, right? How much of this we can do telephonically in advance of a visit, how the percentage of our patients that we have registering for a visit before on my chart. Those are the things John and Margie, I think, are most focused on. But if I don't want to volunteer for them increasing it above 76%, but that's the thing that would make it much higher, is to get that outpatient number, into a more consistent level up at that.
Right. The problem of success is, you just always want more. 76 seems too low now, right? So
I hear you.
But that's great. Well, we'll see if the trend, it sounds like there's still room for improvement to keep improving that on the outpatient side. And similarly, on the patient care revenue as a percent of expenses, I know that has a lot to do with all of the COVID impact on our financials. Do you expect that I don't know, sort of I'm not sure it's a valid comparison to think about how we were performing prior to COVID, but when the target is set at 60%, how what's the thought process behind that? Is some of this more than just the COVID, and how should we be thinking about that?
I think that's right. We initially set it at 60 because the historical data we looked at always had us in the 50s, right? Which is, a significant portion. So a meaningful jump to be above 60s. Of course, we always operate at a deficit. This does not include our dish funding and other supplemental streams, right? Which is critical. Right. The changes from COVID will be that enhanced Medicare rate, and then there will be tweaks in some of our other Medicare funding. But I think it seems as if, for the time being, the intensity of the patients we're seeing on the inpatient side is remaining elevated, and so the reimbursement there is higher and might justify a higher target than 60%. I just based on the history, it's hard for me to assume we'll remain in the 70s, for a sustained period of time. But certainly, in the finance committee, talking with you and John about whether a higher target than 60 makes sense seems wise, because we are moving into our new normal. So it may be worth looking at.
Okay. And on the AR days, where have we always been sort of in the, I should know the history, but is 60 kind of where we've been hovering, or have we been better than that before, lower?
I believe pre-COVID we had approached, if not beaten, this target in certain quarters, and so I think we can get back down there. There's the some of the flexibilities we had in terms of when bills had to drop during COVID, the length of stay that we've seen, and then the sheer volume of testing that is just the front end screening is not there, so the AR happens. The AR starts counting before the financial analysis has been done. I think as we get more routinized and the testing volumes in our system probably decrease more, that 45-day target is a good industry standard. I think Margie and John will probably be pretty eager to keep it there, just so that we can get back down to where we were.
Right. Okay. And the last one, Eric, is more for you on this behavioral health discharges. So I guess what I was hearing you say is you think it's really just a data problem because of the transition between sources. Is that?
Yes.
So our trend was not, we weren't seeing a trend before this quarter. It was a dramatic drop just this one time.
Yeah. So I think the 10% drop is because of the switch over from PDMS to Epic, and that's what Dr. Barron and Dr. Fatal from Office of Behavioral Health explained to me. And so they're working on getting the training of the staff so that we're documenting it correctly in Epic so that the data report can pull it correctly. So I would assume no significant change here, but there are QI projects ongoing. Dr. Fatal's CQFP capstone project was actually on this and providing individualized feedback to providers in real time or more real time on this. And so there are certainly levers that they're pulling to improve this.
Okay.
If I could, I'll just add, Frida, sorry for a second, just, from the managed care side and the district side, like this is a quality measure that's tracked by many of our plans and was tracked by the state during district. So, we have made investments on a program called the Pathway Home, which works with some of our community-based behavioral health partners to engage with some of our most challenged and acute behavioral health substance use patients and track them for 6-9 months to really try to keep them connected. That was an intervention that we've seen have some success. But this is a key area for us, just given the volume of behavioral health inpatient stays we do. And so, further investment and focus in this area is certainly on our minds.
And something post-COVID that certainly helps us here is they are allowing us to count televisits for this metric, which they did not beforehand.
Great. Okay, thank you.
Thank you, Frida. Sally?
Sally, I think, can you guys hear her?
No.
Muted.
Sally, are you muted?
I was muted.
Okay, thank you.
Just a couple of questions and then a comment. On the type of biomed devices, the 20% drop you explained, Eric, was due to the increase in the denominator. I'm trying to get a feel for what that figure is intended to tell us, like that we're up to date at using electronic devices, biomedical devices, that, we're, aggressively trying to free up doctor and nurse time. I mean, what do we draw from that figure?
Yeah, absolutely. So just going back, so biomedical devices could be anything from a ventilator to the monitor that each patient is hooked up to that gives your pulse ox and your cardiac rhythm. And so yes, having them integrated with Epic allows us to not have a nurse go in the room and write down, right, heart rate this, pulse ox that, and then go back to Epic and have to enter it in. The Epic just automatically, right, every, whatever you set it to, 30 minutes, hour, automatically puts that in. And that also allows us to build kind of algorithms on the back end to say, it might be hard if you're monitoring 30 patients on a floor to see small trends, right? Whereas a computer algorithm could pick up a decompensating patient based off of algorithms that you've developed, artificial intelligence, and then can actually alert the nurse and alert the provider to, hey, you should go check on the patient in room 13 because their early warning sign score is concerning, right? And so maybe earlier intervention with a rapid response team, getting physicians to bedside to determine if the patient needs to go to the ICU, or how do we stop that trend from getting worse? And so, right, there are a million biomedical devices in our hospitals, and it's ever growing, as new technology comes out. And so it is that sort of complexity of right, the newest and latest that makes it harder to get them integrated. But certainly the cardiac monitors, the ventilators post-COVID have been prioritized. And so the 80% meant that we integrated 574 out of 714 targeted for that quarter, January 1st to March 31st.
I
The
see.
overall target is 1,700.
Okay.
So we're about 42% of the way towards the final goal.
Okay, thank you so much. Very helpful. On behavioral health, I had previous question about whether telehealth visits are included. You said last time they didn't have telephonic visits. Do they still not have telephonic visits? On the 30 behavioral health appointment within 30 days.
I need to confirm that. I didn't ask that specifically.
Okay. Then Fanny had asked last time how this compares to other hospitals. I think that's a good question. And my last thing is just a comment. I was speaking with Eric about this, and it is really for our chairman. I think that strategic planning committee provides such crystal clear insights into the metrics that we use to assess our performance as a system and to direct ourselves in terms of where we want to be going. And I think it would be useful if every month or every other month we had a presentation to the board as a whole. A lot of what we have is footnoted material. It doesn't have to be every item necessarily, but I just think it's such important information that it should rise to the board level. It's just a recommendation.
Yeah,
Well, so appreciate. I was just going to say, well, I think we'd welcome any opportunity that you and the chairs recommend. But yeah, always happy to present. I think it's good, and it's good to have us all aligned on these key pillars and metrics. So we'd welcome any opportunity.
And Sally, on the benchmarking piece, how other hospitals are doing in New York City, how other hospitals similar to ours, municipal public hospitals, are doing. We will certainly prioritize that when we're launching our new premier benchmarking solution. That's what I felt like we've been missing, over the years is engaging with Premier or another one of these benchmarking vendors. And we did an RFP, Hillary led this, and we selected Premier. So now we're implementing it, but it will allow us to filter by region, by city, by similar hospitals, by all hospitals that use Premier for their quality metrics. And so we'll bring that back next quarter for sure.
Oh, that's great. That's great, Eric.
Thank you, Sally. Any other comments? Any other questions? I just wanted to follow Eric on what Sally mentioned of the benchmarking, and I'm really happy to hear about Premier, because at the end of the day, it's good to know what we're doing, how we're doing, but it's also good to know, like, more or less like the best practices or any trends that there may be that we should be aware and looking at. And so I just have a question. Premier, how broad use is that system? Is like most of the system uses that tool, or how is that?
I'm gonna have Hillary speak to this because she really led this RFP and heard the pitches and information on the latest and greatest.
Yep. So that is, it is specific to the hospitals. So the 11 acute care hospitals, and the measures that are the ones that will be included in it are what are called the quality core measures. It's through the regulatory measures program. So measures like readmissions, diabetes management, so hemoglobin A1C. A lot of the board reported measures are included in that. We just signed the contract for it. So our next step is really implementing it within the 11 hospitals.
I think, Hillary, Benny's question was more of like, what is the Premier user community? Right? Are we signing up for just a really small number of hospitals and systems are using?
Yeah.
So
Okay.
between Vizient and Premier, they're basically cover most hospitals in the country.
Premier's is about 165 hospitals, where Vizient's is probably a little bit more. Vizient's is more of the academic medical centers. It is a very expensive product too, where Premier is a little bit more cost effective. But the beauty of the Premier system is that they're able to create a benchmark group for us of safety net healthcare providers, which is about 60-ish hospitals across the country.
Thank you. I think I would like to follow on Sally's comment that maybe another time you can give us a little bit of overview on how that will be implemented and what kind of intelligence, if you want to think about it, service and operational intelligence, we may be able to gather from this benchmarking. I think that would be, I know I would be very interested in learning more about that. With that, I don't have any other questions, but I know that, is there anyone that has any other comments or questions? I know that I have in my list that Deb was going to give another update, but that was the update that she gave during your presentation, Matt. Is that correct, or is there anything else?
I believe so.
Okay. So I just want to ask, is there any old businesses that we need to address? Any new business? If not, I would like to call this meeting adjourned. Thank you, everyone. Again, thank you, Eric. Thank you, Matt, and everybody for your presentation and really your report on our strategic measures. Thank you so much. Bye-bye, everyone. Bye. See you. Bye-bye.
Thank you. Bye-bye.
Bye.